the family recovery centers. And thank you all for joining us for what will be a very informative and timely webinar. So just first, just a couple of housekeeping items. If you're having or have any technical issues, Ryan is going to be chatting you her email address. So just feel free to email her and she will help you troubleshoot those issues. Also, if I'm assuming most of us are Zoom savvy at this point in the pandemic. However, just a helpful hint, if you, on the right-hand side, if you see all of the panelists listed, if you go up to the box where you see my video right now and you click in the middle square, you will be able to minimize it just to see the person who is speaking. So then you can see, you can have a full range of the actual slides that are there. So let me just take a second. Okay, all right, so first we wanted to just give you a little bit of background on family recovery centers. We are an evening intensive outpatient program for adolescents and their parents. We have 3 locations. We've been in Lake Bluff for about almost 11 years now, and then we also are in Hoffman Estates and St. Charles. We are a DBT-based program, so with that, we have been intensively trained with Marshall and a hands group. And with that training, we also work with ongoing with a consultant from her team in order to make sure that we are staying on the forefront of DBT treatment. And because we're a DBT-based treatment, we really work with a wide range of populations. So we work with adolescents from struggling with depression, anxiety, bipolar disorder, ADHD, also maladaptive behaviors such as self-injury and substance use. We also do urine drug screening as part of our program. Two things I'd like to highlight is that we incorporate the parents into the treatment. So parents are actually on site with their child 2 of the 4 evenings of our program. So they are learning the skills, the DBT skills, right along with their child in a didactic format. And then they're also doing their own work. So they're doing their own processing and really looking at their role and dynamic so that we can really address the whole family system. And then we also have a 24/7 on-call. So staff is available to patients and parents 24/7 in order to help skills coach them through anything that they're struggling with in the moment in their real life. So it really helps acclimate the skills to their own environment. And we do kind of a hybrid of didactic skills coaching and experiential therapies such as yoga and art, as well as processing and multifamily groups. We also have a weekly DBT skills group for adolescents that don't need the intensive outpatient level of care, but they might need an adjunctive to outpatient therapy or need that skills training. So that is us in a very quick nutshell. If you have questions about family recovery centers, I believe you have both my email as well as you will have Ryan's. So feel free to email us with any questions you have and we'd be happy to connect with you. We are very excited to be joining, partnering with BZA to co-host this webinar. We are grateful for our collaborative relationship with BZA. Guys, they are the real deal. They are a wonderful resource in our communities. So with that, I am going to turn it over to Jessica Zaucha, who is a co-owner of BZA.
Hey there, everyone. Thank you guys again for joining us today for what I think we're all really excited about in terms of a very informative presentation. I'm Jessica, as Dana mentioned, from BZA. My partner Jeff is also one of the panelists here today. First and foremost, wanted to thank Family Recovery Centers for their continued partnership. BZA has been around for about 8 years, and I would say that they are probably one of our most important community partnerships, not only in the wonderful work they do in our community with regard to their IOP and their services for teens that are going through some difficult times and helping in their recovery and their family's recovery, but also as community leaders in terms of bringing these high quality trainings and presentations, often at low or no cost, such as today. So a huge kudos and very grateful for what you guys continue to do, and we're grateful to be partnering with you today. So I'm going to definitely introduce Rebecca before we get started with her. But a little bit about BZA. Again, we've been in business for about 8 years. We provide comprehensive outpatient behavioral health care. We do not offer an IOP. That's that we refer to FRC for that. But we do provide outpatient therapy with our group of social workers, counselors, psychologists, and support staff. We provide a number of groups and very specialized services and programs, including some social skills groups, stress management groups for younger children, as well as early adolescents. We have a very thriving DBT program in our Lake in the Hills location, which is one of our 2 locations. We have a Schaumburg and Lake in the Hills location. We also provide grief groups and psychological testing, and are developing a pretty robust treatment program for trauma, which we're really excited about and is part of what brings us here today. Rebecca is one of our lead trauma specialists here at BZA, and not only is one of the people that our team goes to, but also is someone that we often refer to for clients who come in identifying trauma. Of course, we know many clients come in that aren't aware or aren't, that's not their presenting concern, and it comes out in the course of therapy. And she's been instrumental in helping us navigate some of those complex and multifaceted cases. Rebecca has been with BZA for 4 years, over 4 years. She has, her history is rooted in community mental health. She's had an interest and has been a study of trauma-informed theory and trauma treatment therapies really for her entire career. When I met Rebecca, and I'm going to age myself a little bit here, and both of us, but when I met Rebecca almost 15 years ago, we were working in community mental health, and she was a lead provider for the wraparound programming there, ended up supervising that program, and also worked collaboratively with our CNA programs. So she's always kind of, worked with families with different stressors and traumas that they've dealt with in her role in community mental health. She's also worked in the hospital sector as a hospital social worker in the ER, as well as a crisis supervisor. So again, kind of has always gravitated towards those, complex, high-risk families and individuals who need her assistance. And I think that's ultimately what led her to really investing a lot of time and energy into trauma treatment, which has, in a large way, been focused on eye movement desensitization and reprocessing therapy. And that includes otherwise known as EMDR. And she's a level 2 therapist providing EMDR services to our clients, and also does consultation work in addition to her own consultation. She also, in her free time, is a adjunct professor with Aurora University. And so she teaches not only in this area, but many other areas. So she's a very experienced and seasoned presenter, as well as teacher. And again, we're just excited to have her here today. Before I turn the controls over to her, just a quick note, you'll all notice that in the bottom middle of your screen, there's a Q&A screen. Please feel free to ask questions throughout the presentation. Rebecca felt it was really important not to hold questions. We may not, in order to get through what is a lot of material today, we're not going to disrupt the presentation for questions frequently, but Rebecca is going to make sure she takes time periodically to answer those questions and make sure that she is able to answer things in a timely manner. We also will be responding briefly if there's something that we know we're going to be getting to in a couple of minutes. So know that your questions are being viewed and we will get to them. We're also going to try and find a few minutes at the end for some discussion. So without further ado, I'm going to hand the controls over to Rebecca. Thank you guys all again for being here today.
Good morning. I'll fix this a little bit for you. As Jessica said, I'm Rebecca Ciesla. So we're going to spend a little bit of time this morning talking about trauma, assessing for trauma, and what that looks like with some of the challenges we have right now in the world, and what we're seeing as well. So this is a little bit different format for me, not being able to see all of you. So please do share your questions as we go. I can't necessarily see. I'm going to kind of check as we go through some of that, but I know Jessica's going to be looking for me and kind of jump in if we need to. But I want to be able to have that discussion as we go, and those questions not to be lost throughout this. So please make sure you're sharing that. Thank you for taking that time this morning to kind of sit with us and talk about this. I know how important this is. So let's get started. We're gonna spend a little bit of time in the beginning just talking about some of that neurobiology and some of those things. And I've got several slides in here regarding that, and some of them I'm gonna kind of go through a little bit quicker, more so because I want to make sure that we have enough time to really talk about some of that assessment piece at the end. But I put in all of that so that you have it, and really because it's so important to understand how the brain works when we're talking about trauma and what that looks like as we're treating it. So Shirley, if you have any questions about that, we can also talk about that as well. Looking at just trauma in general, and I put this in because I think it's so important for us to remember that when we're talking about trauma and we're looking at trauma-informed care, regardless if your goal is, or you're already working with folks who struggle in that area and who have experienced trauma, the reality is worldwide everybody is experiencing trauma right now, and most patients as they come in, it's not uncommon for them to have experienced a trauma at some point. If we want to dig in, as Jess was talking to you about my career, a lot of my patients come in and they have experienced trauma, and that's really kind of my niche. Not everybody wants to do that, and that's okay, but just recognizing that it's important to have that knowledge about what trauma kind of looks like when our patients come in, so that we can recognize it and understand, even if that isn't your niche and you know that you're going to refer maybe that situation to someone who is more experienced, just so that we can have that lens and recognize when it's there. And so it's so important to see this, and especially I teach a class for Aurora University, as well as working for BZA, and on the effects of trauma for children. And when we look at kids and we see that trauma, it's really important to look at that as well for those of you who work with kids too, and look at that misbehavior. Sometimes isn't always just misbehavior. So when we look at trauma, we want to remember that it's objective, not subjective, right? And so when we have a situation that makes us leaves us feeling overwhelmed, alone, that can be traumatic. So when we look at a situation and you have two separate people in the same exact situation, I heard an example at one point, and it kind of stuck with me, and the idea that if you have two people and you're sitting there and maybe a firecracker goes off in the front of their feet, one person may experience that as not a big deal, it was fine. The other person experiences that as very overwhelming and traumatic, and the way that their brain experiences that and takes that and holds on to that as an emotional experience is going to be very different than the other, and that becomes a very traumatic experience for that person on the left. And so it's very objective and it's not subjective, and we have to remember that as we go forward. And so the more frightened and helpless you feel, the more traumatized that becomes. Missed one, sorry. Just these two slides just for you to look through. I'm not going to read through all of the symptoms, but looking at, and this isn't all inclusive, but looking at some of those symptoms that we can see through trauma. And when we're assessing for people, kind of looking through some of that. So looking at that shock, that denial, that disbelief. Anger and irritability are really, really common things that we see. That mood swings. I've actually had patients, several patients that I have worked with be misdiagnosed for things like bipolar disorder because of those mood swings, when it was really a trauma experience, and it was all trauma related, and because they were having triggers, and it appeared to be more bipolar symptoms because those providers weren't trauma informed. So looking at some of those things and recognizing it as you go. Confusion, difficulty, concentrating is a big one. That anxiety is huge. Withdrawing from others. Avoidance is a big one, especially when they're avoiding anything that's going to trigger any of those flashbacks or uncomfortable feelings can be huge. I worked with a patient at one point that really didn't recognize that it was a traumatic experience. And as we were kind of talking about things and I was assessing, he had told me that he hadn't stepped foot in the entire state. It was a southern state. He hadn't stepped foot in the entire state for years. And as we started talking about it and figuring it out, he had a very close relative who had passed away in that state. It was a very, the passing was a very difficult passing. It was not expected. The family member had been, it was a homicide down there. It was very difficult for him. And for, I think it was right around 10 plus years, he had not gone into that entire state. And so it was really looking at that and processing through. That was a very traumatic experience for him. And obviously there was a lot of avoidance there. So looking through some of that. So some of those physical symptoms that we can see as well, some of that heart racing, aches and pains, fatigue. Again, look at that edginess, that agitation, that physical freeze when we say the muscles contracting, the disruption in that brain development. We're going to talk a little bit more about that later. Insomnia, nightmares, night terrors can come into play there when we're talking about trauma. Easily startled is a really big one. That hypervigilance is really huge, can come in, especially we see that a lot with kids, but certainly with adults as well. So let's talk a little bit about that brain changes. I don't know if anybody, so I can't always see all the questions in here. Jess, you're gonna have to tell me about questions because I can't.
There are, the only question so far has been whether or not the PowerPoint's going to be shared, and I know that we will be sharing the PowerPoint at the end, but so far no questions, and but yeah, when you pause periodically, I can let you know if there's any.
Thank you, I cannot see them. Okay. Yes, we will absolutely share the PowerPoint. So remembering this slide, I'm not gonna, this is just really for your view, but knowing kind of where we are with the right and the left hemispheres, and recognizing, and I'm going to show you some scans later, but that, that left hemisphere of the brain is really where our speech and our logic, how we analyze, and then that right is our creativity, daydreaming, imagination comes from. So looking at our brain development, and when we're talking about that, the brain organizes from the bottom. So we're talking about the brain stem up, and it goes from the inside out. So the reptilian to the limbic to the neocortex. Okay. So as we talk about that, and as we look at how trauma affects the brain, that's going to be important to just note, and that the brain is really underdeveloped, and obviously at birth, but doesn't complete its its development until we're in our 20s. So when we talk about trauma occurring childhood, teenage years, that's really significant to our brain development, and the impact that it can have for those kiddos, for their emotional maturity, the reasoning, all of those things. So these are just, for those of you who aren't aware of what each system within the brain is, the functioning that they're doing, I just want to make sure that everybody's aware as we're kind of talking about that brain development and what each symptom, some of those focuses are. So when we're talking about the limbic system, the memory, the emotions, that assessment of danger, your amygdala is in there, and looking at that piece. What your neocortex, the function is there, your language, your abstract thought, your prefrontal cortex is in that neocortex. And again, that development isn't completely done until later on in your lifespan, because your brain isn't fully developed until your 20s. Your decision making, your prefrontal cortex, I always, especially when I'm talking to my younger kids and we're talking about how our brain works, we always talk about that prefrontal cortex. It's kind of our sheriff of our brain. It makes it's like the rational, logical decision-making piece of our brain. So it's a way for them to understand. That's kind of the way for it to help us to reason things out. These are the things that when we're talking about trauma, understanding these pieces are really important. So a brain that doesn't experience trauma, what's going to happen is information's going to come in. The thalamus is the intake center of the information. It's going to send it to the amygdala. That's going to either say, okay, everything's going well, or it's going to send out the alarm system. It basically determines if there's a threat or not. It's going to send out those signals if there's a threat. Stress hormone is going to be released. Your hippocampus is going to relate any new information to past experiences. It's kind of your library of your brain, essentially, saying, okay, is this, do we have any memory saying that this is a threat, or that that this isn't a threat? And then people without trauma, that prefrontal cortex is going to use that logic and rational thought to determine a response. People without trauma, the body, the brain, it's going to assume normal functioning after that. This survival mode is going to happen. It is going to kind of work in this way. And then the body's just going to go back to its normal daily routine as if everything is functioning the way that it should. The issue becomes that people who have experienced trauma, our brain is always on alert for anything that's going to suggest danger. Anything that might be further traumatizing, any reminders of those traumas, which we call triggers. Trauma essentially is anything that our brain isn't prepared for. So our brain is always trying to be prepared for a trauma in those moments. It doesn't want to essentially come into contact with something and not be ready. So it is always waiting for the next thing to happen. So what happens differently in the brain with people who have experienced trauma is all of those things that we talked about before, those things are going to happen much more quickly by the amygdala. That stress hormone is going to be released by the body, and they are going to go into fight, flight, or freeze. So those other areas are going to essentially be shut out and not consulted, and that stress hormone is going to be released. even when those threats are irrational or not in there in the sense that those around them don't see them, right? So people with trauma are also often flooded with that stress hormone, often, sometimes all the time. And that can often make them, you think about it in general, right? Think about a moment where you had, you felt like you were in danger and we shut down, or we got really anxious or angry, or whatever that could response that we had. But this is happening on a regular basis, so they're heightened all the time. Sometimes they recognize it, sometimes that they don't. So it's not uncommon for them to feel agitated and aroused, agitated because they're aroused all the time. So I told you I taught a class specifically on the effects of trauma on kids. So I do have some slides on here specifically for trauma to children, for obviously, because I've done some of that work as well. But I think that's important for a couple reasons. A, there's lots of us that work specifically with kids, and B, when we work with adults who have experienced trauma as kids, we have to recognize that these things have happened to them during that time. So they often have experienced these things, or their brains have changed in that way. So remembering that they have often a smaller hippocampus, and so that they're right, that memory piece, that learning, that memory, that stress response is smaller. A smaller prefrontal cortex. It's not fully developed already in that period. And they have an overactive amygdala. So these are things we can work on, but if we're working with them as kids, one thing, but if they've never been treated for trauma and they're coming to us as adults, these things are all probably the case. So we have to recognize this and remember this as we're working with them. So I've got a couple brain scans in here too, to remember that as we're working with them, and when we're talking about looking for signs and symptoms and assessing people, these are important things to look for as well, talking about all that brain development. And when someone is in a period of traumatic stress, what they have found is in those brain scans of people that the left hemisphere is far less active than the right. And if you remember from that first scan that I showed you of the brain development, our left hemisphere is our logic, our sequencing, our language. So think about especially our kids who have less, their brain development is not as their brain hasn't developed as much as an adult, and so their vocabulary isn't as large already, right? It's smaller, and so they've got less to choose from. And so they're struggling even more with finding words of what's happening, what's going on, trying to put those things into sequence. And that makes a lot of sense then when we're trying to figure out what has happened with them, or why they're reacting in those ways of acting out. So here are the brain scans, and again, we're going to share this so you guys can look through this, but this is just the idea of with an abused brain, someone who's experienced a trauma there on the right, and then a healthy brain on the left. So again, just talking some more about those stress hormones, those cortisol levels may be higher than normal, which is linked to behavior issues, health problems. Talk a lot about the idea of when cortisol levels get up, and just in general, that there's a lot of health issues that come into play with that, especially heart issues. So looking at that piece is really important as well, and that connection there. There's keys to looking at that stress hormone as well, with the heart rate, the blood pressure, the rate of the breathing when they're the body's going into fight, flight, or freeze, and where they're at with that. So we talk about that chemical imbalances, decreased serotonin, dopamine, and the look of some of that and how they're affected by trauma. We'll talk at the very end when it's important to maybe refer to a psychiatrist as far as looking at trauma. Certainly there is a piece of this when we're talking about symptomology, where medications can be helpful to target some of those specific hormones. But remembering as we're looking at that medications in general don't treat trauma. They may treat some of that symptomology. And so we'll talk a little bit about that at the very end. But they're not going to treat trauma in general. But they may help with some of these other things like decreasing that serotonin or dopamine. So again, this is just some more of those manifestations of those neurological changes related to trauma. Kind of talked about some of these, and again, some more symptomology to kind of look at when we're assessing people, and looking at that connection to trauma. So let's get into some of the meat of what we really want to spend most of our time on, and that's really looking at trauma screening, trauma assessments. I want to talk a lot about questions to ask, how to ask questions. I want to spend time on how to make the environment safe, and looking at some of those pieces. So when we talk about a trauma-informed screening, that is really talking about just a very brief, focused inquiry to determine whether or not if someone has experienced trauma. That's it. Did it happen? This is really done super early. We're just asking some very brief questions about some specific types of trauma. So this might be in the very beginning of our intake process. Are there any traumatic experiences that have happened? And these are very brief questions. So I might talk to a patient in the very first time I meet them. So I think what we have to remember, and we're going to talk more about like assessments in general, and I think what we have to remember is I'm going to do a trauma-informed screening the very first time I meet a patient. Remembering that I'm doing a trauma assessment throughout the time that we're working. It's not uncommon for patients who have experienced trauma to not come out with all of that the first time we meet them. They have to feel safe. They have to know that they can trust you, trust the environment that they're in. So, you know, not all of us work, like I work in a private practice, and they're having some interaction with some of the people who work in our front desk, but most of the time that's somewhat minimal. And then they're coming into my office, they're having most interaction with me. For some of us, there's bigger organizations, and they're interacting with lots of people throughout the organization, and they really need to feel safe and comfortable wherever they're coming in throughout that organization before they're going to start sharing that level of trauma and intimacy with what happened or what's going on. So I will get patients referred to me, and I will have people tell me, like I'll have them referred to me from other therapists in our office and say, can you work with this patient on this specific trauma for EMDR? And I'll say, absolutely. I will do an intake with them, and they will not give me half of the stuff that first therapist told me. That's okay. They're not going to. They don't feel safe with me. They don't feel comfortable with me. So we're going to do this trauma-informed screening. We're going to talk about those key things. And I'm going to give you some of those questions, right? And we're going to talk about what kinds of those specific traumas, and, you know, abuse, sexual abuse, and we're going to address those, but knowing that I'm going to continue to do a trauma-informed assessment throughout the time we're working together, as they feel safer, as they feel more comfortable. That's when that work is going to continue to happen. So the assessment is more in depth. And what I always tell patients whenever I'm asking questions, and I'll do this for my intake in general, is I'm going to ask you some really tough questions. For some people, these questions are not difficult, and some people they are. If there's any questions that we talk about today that are difficult for you, know that it's okay to, that if you're not able to answer them today, that's okay. Just let me know, and we can move forward from there. It's always important for them to know that they have the right to say no, and that they are in control. So we talk about what was the trauma, when was it, and how does it affect your life. So I am typically asking about different traumas. If they've experienced any type of physical abuse, sexual abuse, and I'll tell you how I ask those as we go through here. And then we'll talk about how did it affect your life, and oftentimes you're getting that just through the conversation. Okay. I will often ask them as well is, and most of the time I actually don't even have to ask them, but if it doesn't come up, I will ask them, have you ever talked about this before? Have you ever gotten treatment for this before? Does anyone else that's close to you know about this? Okay, so asking about trauma. There's a couple misnomers that I think are really important as we talk about this. It's really a misconception that people believe that it's too upsetting to talk about it, so they just don't ask. Or the other one is, if patients want to talk about it, they will tell you, so we don't have to ask about it. The reality is that if we don't ask, patients aren't going to feel like they're supposed to tell you. It's really important for patients to feel like they're able to talk about it. So putting it out there and saying, it's okay for you to talk about it if you want. And reminding them that it's theirs, it's their story, and they get to talk about it when, how, and with who they want. So what we want to do for them is to explain what trauma is and allow them to identify with the definition. So a trauma is when someone is hurt badly or sees someone being hurt so badly that they are just unable to cope with it. Something that is hard to stop thinking about, and people might feel like that it's still happening over and over, though they try really hard to stop thinking about it. Do you think you've ever had a trauma? What I will often say to them is things like talking about things like that trigger, where there are things that, so this is a really good example. There's also examples like where there are things that get brought up, right? And so patients will talk to me about a traumatic experience, and we'll talk about things like, well, we avoid situations because it reminds us of something that is so overwhelming or painful. And so it brings up those same feelings around that event. We smell something, or we hear a sound, or a specific place, and so that becomes so painful we start to avoid those things. So we start talking about situations or examples in those ways. And so looking at those pieces and explaining that to patients is important for them to understand. And then we start talking about things like natural disasters, right? Accidents. And when I talk about serious accidents like car accidents, we talk about that in a way of, have you ever been in an accident where maybe you've had to go to the hospital, or where it has been, we might talk about where it's been traumatic in this way, and we talk about that example of, do you have a hard time getting in a car, seeing a car, avoiding that piece, or explaining that in more detail. The loss of loved ones, physical abuse, emotional abuse, sexual abuse, and racialized trauma. I think when we talk about deaths and what we also remember is losses in general can be traumatic. So when we talk about deaths, it's not always a death of a person. I have patients who I've worked with who have had losses of pets, deaths of pets that have been horribly traumatic for them, that have really impacted their functioning, have held them back in life, and they've had to really process that. Also just the losses in general. Losses of friendships, losses of, we're talking about losses of jobs and what that's meant and for them, and talking about right now we're talking about COVID-19 and the losses that have been experienced across the continuum for people. We talk about some of our students and the losses that they've experienced and the difficulty with some of that. And so looking at that and understanding that, when putting that in and understanding that there's also an idea of loss that can also be traumatic for people too. I know I see some questions popping up there.
Yeah, Rebecca, there was a question that about, are there training recommendations for bigger organizations where often the first point of contact is a receptionist? So I think you kind of spoke a little bit to this, but do you have any specific recommendations for larger organizations, for training those receptionists? Kind of the first thought that comes to my mind is maybe some mental health first aid, but anything more trauma focused.
Well, I mean, I obviously think first, mental health first aid is important. I think for them to recognize, I I don't have any like right offhand for them. I'll have to look for some of those ancillary services. I think certainly some trauma-informed, even from staff who are trained in trauma, or just doing some smaller work as far as understanding and recognizing trauma and having just a trauma-informed understanding is really important. But I think, let me look and see if I can get some more specific trainings that would be helpful.
Thanks, Rebecca. And yeah, just to reiterate, I've seen a couple of questions come up again about the PowerPoint. So just to reiterate, we will be emailing to the email that you have signed up for the presentation with. That's where we'll be sending the PowerPoint.
Perfect. Good, keep those coming. Okay, so when we continue to talk about this assessment, we kind of talked about this idea of allowing the patients to be the lead and contribute to their sense of control with this process. So as we do that, I will on a regular basis have this conversation with my patient. So this is not new. This is not like something I tell them in the beginning when I do an intake and then we never talk about it again. I have this conversation with them on a regular basis, when not like every single time they come into my office just for no reason, but when they whenever we're working, you know, obviously if I'm working with a patient specifically with trauma work, but anytime if I'm working with any patient and we're not working specifically trauma work, but something comes up in related to trauma work, I will have this conversation with them. I'm working with a patient specifically right now. We were not working on anything trauma related. As we did more and more work together, some trauma work started to come up. And the thing that I have noticed, not uncommon, is we'll have patients that will go to therapists who aren't trauma informed, and then they'll come and see me at some point. And it's not any fault of the therapist that they've seen in the past. I think it's all good intention, but without the trauma-informed care, what I'll find is patients have a harder time than opening up. And so it sometimes is a longer process. And this patient, I'd been seeing them for a while. They said, then they started talking about some trauma. And that was the thought that they said is, as I started talking to them about, this is your story. We talk about it when you are comfortable, how you want, in the way that you want, and then it often will come out. I tried doing this, you know, with another therapist, and it was difficult. I was pushed a lot, and so recognizing that it's important to step back and not push. They really have to be, and I use the analogy with them a lot of, you're the captain of this ship. I don't have control over this. It's not for me to say when you talk about it and how you talk about it. So whether I'm doing EMDR with them, talk therapy, trauma-focused therapy, it is all where they're at. And I'm very clear with them about the steps of either the assessment or treatment or what we're working on. Okay. And looking at all of that stuff. And when I do assessments, I'm always saying, these are questions that I ask everybody who's coming into my office. And that is where we often have that conversation of, that's why, you know, that's why some are hard and some are not. And these are, and as we go through and talking about that and being very clear for reasons for everything. and knowing that they have control over all of that. We talked about this a lot, being just clear that it's their right to answer or not answer. They just have to let me know. We'll continue going through. If something's really difficult and they just want to talk about it being difficult, and we can do that as well. I want to make sure that we're addressing any increased symptomology that's coming up with the question as it occurs, and recognizing that we can address that symptomology without having to address what they don't want to talk about if we need to. So let's talk about specifically what kind of questions we're going to ask. So what kind of trauma? And we talked about those specific traumas that we look at. And I'm not going to say to a patient, what kind of trauma did you experience? I'm often going to say to a patient, I'm going to go down that list and speak specifically and ask them specifically about those traumas. Part of looking at this and part of assessing for trauma is also recognizing your comfort level with it and being comfortable. Because when we're not comfortable, our patients are not going to be comfortable. So we have to be comfortable in having those conversations and the answers that are going to come from it. So once we've had that conversation, once I've asked them about that specific trauma. So if I've said, and again, that question is going to switch. So if I'm asking an adult about sexual abuse, as opposed to a child, which to be very transparent, I don't typically see any kids under 12, but if I'm going to look at talking about, a younger kid, right, developmentally, I'm going to ask something like, has anybody ever touched you in your I'm going to ask age appropriate questions, right? So has anybody ever touched you in your private areas, and that you felt that you didn't want to, that you felt uncomfortable? Did they ever tell you not to tell? So those key questions, right? When I talk about it with my teens or my adults, I'm going to use those age appropriate questions. I see a lot of teenagers. Has anybody ever touched you sexually or that you did not want to, that you were uncomfortable? Has anybody ever forced themselves on you? So it is direct in the sense of asking them those questions. And it is okay for them to say, I don't want to answer. And it is okay for them to answer, but also to say, I don't want to tell you when, I don't want to tell you who, I don't want to have any other conversation about it. And that's okay too. And it's important for us to recognize body language and where our patients are at when they're talking about it. I always ask so I see patients 12 and above. If I have patients who oftentimes maybe they want their parents to come in, I always ask them prior to an assessment if they want their parents to come in or not. They have that option. It's their choice. And I will ask them before some questions if they want, how they're feeling, if they want mom and dad to stay in or guardian or whoever came in with them, so that they have the option to answer questions alone if they want to. But we will talk about some of these if they're comfortable. Do they still have contact with those people? And it does still happen that they do, even with adults that I see, where I've seen adults who were sexually abused as children, where it was someone within their family and they still have contact with those people, sometimes regularly, sometimes not. And so having those conversations. And remembering that sometimes this assessment happens when I see them first, the very first time I see them, and sometimes this is happening throughout. And sometimes I've seen a patient for a year and then they say, oh, I've been meaning to tell you. And then this all comes out, all of this happened. And then we start talking about, okay, let's talk about all of this. And then I'll still start asking these questions. How did that affect you? What occurred after this happened? What did you notice? Do you still talk to this person? How long did you talk to this person after this happened? Did you ever tell anybody? Did this happen once? Did this happen lots of times? So regardless of when this comes out in our treatment process, I'm still asking these same questions. So also talking about assessing trauma, looking at that, we're talking about assessing racial trauma too, and putting in questions within this.
Hey, Rebecca, I'm sorry to interrupt, but I think there's a question really related to your last slide. So before you kind of go into a different topic, I think this is a good question. So what would be, as clinicians, what are our legal and ethical responsibilities if a client only tells us that they were abused and doesn't want to talk anymore about it, which I think, dealing as a mandated reporter. So what if the client is still being abused and they don't want to talk about it? I think just speaking to the conflict between our roles as trauma-sensitive therapists versus mandated reporters, and sometimes the urgency we feel to get that information.
Okay, yeah. So looking at if we're working with someone who there's a mandate to report and there's still some abuse happening, and getting all that information absolutely is important. And so obviously, I always let all of my patients know, my kids, my teens, everybody know that I'm a mandated reporter in the beginning of my work with them and how important that is. And so working with them, what I would say is we have to be careful in a couple ways. We want to be sensitive to where they're at, right? And recognizing where they're at. And we also want to be a safe place for them and to be able to continue to work with them and know that they can trust us. We can still report concerns that we have, even if we don't have every single specific piece of the information. So the reality is, whatever information I can get is great, but I am not the forensic interviewer to get every single piece from that patient. And so if a patient is reporting to me that if they're someone who is in that population that I need to report on, and they are currently being abused and I need to report that, and I am not getting everything, it's my job to report that. It's not necessarily for me to dig and get everything. I want them to have that safe space. I want to get the information that they've given me, and I can still report what I can report and give them all the information that I have. Does that make sense? Not sure who asked that question, but hopefully that answers. lost control of my computer. Hopefully that answers your question. Because we also want to be able to continue to have that safe space. We can report what they're giving us and continue to do that.
Hey, Rebecca. Yeah, I think you're definitely speaking to that, and I you know, kind of a follow-up question here. I don't know if this is from the same person, but what if you aren't sure if they're still being abused and the client doesn't want to tell you if the abuse is still happening? I think some of this probably starts to get into an area of clinical decision making about the importance of reporting something that hasn't been identified in kind of our own experiences with DCFS and those types of calls versus being patient to gather that information and building the rapport. Yeah, go ahead.
Well, and again, I think we have to remember that it's whether or not it's still happening, not what we need to do is report. And I know it's hard, right? I think you just kind of hit it on the head, Jess, is that sometimes it's difficult to put that in the hands of somebody else. And that's difficult for us. What helps sometimes is that that kid's still coming to us. We're building that safe space for them, that they're going to continue to come to us so that we can continue to work with them and continue to get that information as they're there. But we've reported that so that way the people that need to know, and they can look into whether or not it's still happening. We don't need to dig into that. If we have a concern that it's happening, we report it.
And I think another follow-up to that is, in that example, how do you approach reporting with that client? To your point, you're trying to maintain the security in the relationship. There might be like a conflict of interest to tell the client that, hey, you don't need to talk any more detail to me about it, but I am going to report this to someone who potentially is going to follow up with you. However, I think in many of our experiences, not telling the client that we're making the report also can feel like a violation. So again, I know that there is, a lot of these are case specific, but any advice you'd give on how you'd approach that reporting responsibility with the client?
So again, I always have this conversation when we first start. That's my first thing that I have with the patient that I'm working with any guardian or parent. I have that conversation first off when we first meet. When I need to break any type of confidentiality, what that looks like, and then we'll have that conversation. And it really depends on the situation and safety and what that looks like, who I'm going to tell within that situation. Obviously, if I'm concerned about abuse from a caregiver or a parent, whether or not I'm going to tell that parent, right? And having that conversation in the sense of safety and helping, and the idea of answering questions and spending time to talk about what my role is, and that part of what I do is to help keep people safe. And this is part of how that I do that if it's a kid. And just looking at individually who it is, what that situation is, what the rapport is with that patient, and utilizing that as part of that conversation. So it really depends on individually how that situation occurs.
Thanks, Rebecca. Yeah, I think these are obviously pretty high anxiety situations when that, and it just speaks to how often that trauma sensitive assessment and treatment can go in contradiction to some of our other responsibilities and kind of the systems that that we're working within. So recognizing that there's not easy answers to these questions, but they're great things to be thinking about, I think.
Yeah, absolutely. Because Good questions. Okay, so again, when we're talking about assessing trauma, remembering that trauma, we talked about a lot of different traumas. Also remembering that racial trauma plays a part into that as well. And so it's important for us, I want to speak to this a little bit, and we're going to talk some more about this as we talk about some of our current events. But talking about, as we address trauma in general, we kind of talked about the idea of feeling comfortable, right? And having the ability to be comfortable as we assess trauma and talk about trauma, and making sure that we're comfortable so that our patients are comfortable. And the more comfortable we are and the more that we provide that safe space for them, the more they are going to be able to have these conversations. This plays a part, obviously, into that idea of racial trauma too, and just being able to have a conversation around racial trauma and feeling comfortable about doing that. So having conversations about how our patients and their significant others identify racially, and how their background has been potentially a source of pain or hurt, humiliation, pride, or strength. I think those are all really important. And recognizing that although we're talking about trauma, that we also have to recognize that their race or cultural background is also, although it can be intermingled, right? And so we don't want to leave out that piece of pride and strength that is a component of that as well. We can explore the possibility of the connection between the client's racial encounters with their presenting concerns. And we also really have to recognize and then take into consideration any racial composition and potential power of difference in the therapeutic dyad. So I think this is important, and recognizing that that can be difficult, right? And so I think you guys can all see me in my little screen there, and it's pretty you know, when you look at me, I'm a Caucasian 40-year-old female. And so when I've worked with patients and working with patients with some racial trauma, it's important for me to recognize that with them. It's important for me to recognize with my patients who are who have experienced racial trauma. It's especially with my patients who are Black, who are Indigenous, who are people of color, that there is clearly a difference. There's clearly there's experiences that they're having that I cannot completely understand. And I recognize that, and I understand that, and if they're comfortable talking to me about that, I want to be able to talk with them and have that conversation. And if again, this is their story, and I want to listen and be able to assist them with that piece. But I also want them to know that I recognize that I cannot completely empathize, or I can't completely understand. I can empathize, but I can't completely understand what that feels like. And that's okay for me to tell them that, and to kind of bring that out, right? There's that elephant in the room, and that's okay. And to have that conversation. And I've worked with people in different situations and been able to work with them through some of that and recognize that there's some differences there, but it's working through that has been helpful. So we want to talk about the difficulty in functioning after trauma as well. How did those trauma symptoms exist before the trauma? And what are they like after? So looking at some of those comorbidity issues. Okay, if someone is drinking and they have substance abuse issues, if they're using or drinking and is this new? Was this happening before the traumatic experience, or did this just occur since the trauma has happened? Is this a way for them to avoid the trauma? A commonly used word that you'll probably hear a lot when you're working with someone in trauma is numbing. That is a usual word of how to just express what they feel. So the word numbing. And so is this something they're using to kind of numb that, or do they feel numb? And then asking about the impact of trauma on areas of functioning like school. Are they getting in trouble more in school? What's happened with their attendance? Are they refusing to go to school? Are they avoiding things in school, certain classes, the bathroom? Are they avoiding certain hallways? Are they avoiding certain teachers or kids? Are they just avoiding to go to school in general? How are their grades? What are their family relationships like? Separation anxiety, any conflict that they have there, peer relationships, and then that health in general. Again, even looking at, so we talk here like changes in sleep, eating, somatic complaints, and that's stuff we look at, I think, a lot as mental health workers. But we also, it's also okay to look at like physical health. Is there any physical health changes since any traumatic experiences? And so some of those things we were talking about before, like they might have noticed, and I'm going to the doctor and there's, I'm now on medication for blood pressure because my blood pressure is high. I've got some heart problems, things like that can also be associated sometimes with a traumatic experience, or that increase of cortisol for long periods of time. So the question there now is, how are we going to use this information? What are we going to do with it? We're going to identify what the aspects of the trauma have the biggest impact on the client, the family, any collateral, right? What are the aspects of the trauma that are the biggest impact? This will help us just understand kind of what's happening, get that picture, right? We want that big picture and that cultural aspect. This will help us guide towards any of the problems that we could address. Part of this is what I always say to patients are, what are you looking to get out of treatment? What are you looking at with what we're talking about that you feel like would be most helpful to address? So when I'm looking at how to use this in assessment, I am asking my patient, well, what within this, when we're talking about, especially within the trauma world, of what pieces of this would you want to address? So sometimes my patients will say, well, I don't really want to address the traumatic experience, right? Because they're not ready. They're not ready to go there, and that's okay. But I want to address the anxiety and all this stuff that's happening because of this. So I don't want to address the situation that occurred, but I want to address the fact that I can't go to school. Okay, so that's what we're going to address right now. Now, is it a reality that sometimes it's going to be more difficult, right, to get all the way to where they want to be when we haven't addressed the core issues sometimes, but they're not ready to go there. So if we're not going to get anywhere by trying to push them. So let's start where we're at, get them, help them feel safe, and then if they get to that point, that's great. Okay? So again, just talking about the services that they need and how they could be more helpful. Talking about regulating emotional states. What's the support system that can help a kid feel protected and help protect them in general? So when we were talking about the idea of like this kiddo was saying that they're still being abused. What are those supports that we might need to access to make sure that they're protected? That's important. And recognizing that, I think I saw like 70 something, 76 participants that are on here. Everybody's probably working in different organizations and doing different things. And so we all have different roles and functions. And so some of us might be working in hospitals or doing functions as case management or working as therapist or working in larger teams. And so what are those roles that we can be doing, and how do we work together to support those patients as we work with them? So let's talk a little bit about current events. Am I missing any questions here? Nope, okay, good.
Nope.
Okay, so let's talk a little bit about current events and how this plays a part into how we're working with trauma. So the piece, obviously, we're saying, right, COVID-19, we can't go anywhere without hearing about COVID-19, the virus, however we want to talk about it, Corona, whatever word your house or your organization uses to talk about it on a regular basis, this is everywhere. And as a world, as a nation, there's a huge impact in so many ways. And although it is health-wise this huge pandemic that we are dealing with, as far as mental health and trauma related, it's also been, we're seeing some consequences there as well. And I'm sure all of you are as well. And the piece that we have to remember is this. As well as our patients that we're seeing coming in are experiencing all of this, we are too. We're all going through this. And so as we're treating people in whatever capacity, right? Be it mental health, be it health-wise, whatever capacity, and not only our patients, but most of us who are in the caring profession, we're then also treating, feels like we're treating then those around us that are our loved ones, right? Because they often come to us anyway for, when they're struggling, and so we become a support for many around us. And so recognizing that there is all of these consequences related to that, and what we're seeing a ton of is this idea of grief and loss. When we think about this, I think a lot of times people go to this idea of the first thing is the loss, and definitely there is a loss of those who have lost their life to COVID-19 and those loved ones who are still here, mourning that, and that has been huge. The loss of the ability to mourn in the way that some have generally been able to prior to a pandemic like this, that is huge. But then we also look at so many other ideas that are around that grief and loss, the loss of the connection with people, the loss of just being able, like we talked about, when a loved one passes, whether it's been from COVID-19 or not, the ability to mourn them. I have a patient who I just worked with this week who lost their grandfather, they were significantly close to. This patient has a long history of trauma to begin with, and so when someone already has trauma going into a very traumatic situation, it often will spark a lot of those symptoms. And so she has been doing relatively well, but this is very difficult for her, obviously just mourning the loss, but then also not being able to see him as he passed, not being able to be there. That's a huge loss for her, and related to COVID. And he did not pass from COVID, but there's just all these other trickle down effects that we have to look at as well as losses from, we've got people who are losing jobs, and then those trickle down effects from losing jobs and losing your home from that, or things that happen due to those things, losing your businesses, all due to COVID-19. We've got those of us who work with kids who, were seniors and lost the end of their senior year, or lost, missed out on things like that. And some of us look at that as not as significant, but for those kids, that was huge. And remembering that those responses are objective, not subjective. Exposure risk around this is huge for a lot of people, and can be very traumatic in the sense that, remember your own responses potentially sometimes, and the look of, when we're coming into this and shelter in place, and then as we start to open up and going back out into the world, can be very anxiety provoking and even traumatic for people as they start to be concerned then of exposure risk, and the guilt of, will I get somebody else sick, feeling sick yourself, and whether or not it's symptoms related to the virus, and what that feels like. And so looking at all of that and how that relates, and how that can all be compounded with a pandemic like this, is huge. And so remembering how that all can play a part into all of this is important for our patients. And it's also important when we talk about this is to have a lot of education for them. And I talk to my patients a lot about, this is very natural, and normalizing this so that we can work through it. Because a piece of this seems so overwhelming, and and when you feel that way, you feel like something's wrong with you and you're the only one. And so when we normalize it and educate on it and assist them with that piece, it's much easier to then learn those strategies and work within it and help de-escalate some of that. Does that make sense? I don't see any questions around that, so I'll keep moving. So if it wasn't enough that we were kind of talking about that, we also have a compounded trauma for a lot of people, right? We can't just allow people to have one trauma. People have to have lots of trauma right now. And this racial bias and prejudice and hatred that we're kind of looking at, this slide is my transition for people right now, is this compounded stuff we're talking about right now. And when we talk about this, we're not only talking about this related to current events, but we're also talking about this related to COVID-19. Lots of people have experienced this also related to COVID-19 and trying to get treatment. So there's that piece added on. So it's this compounded traumatic experience. So there's this racial trauma, and then we have the pandemic. So there's this compounded trauma for people, and racial trauma is not new. Let's not pretend that it's new, because it's not. We know that it's not new. So with the pandemic, that's adding another layer. And then what we're, obviously with some of the pieces, and we're going to talk a little bit about this with the videos being out, we'll talk about that, is also adding pieces of that as well. And the added components right now of racial trauma that's been added is huge as well. What we want to talk about. So is there a question before I get started, or can we hold off on that one? So when people of color experience racism, we have to remember that it's not only bringing up their experiences of racism, as well as their awareness of a very long-standing history of racism. And so that's a huge piece. This isn't, so when one thing happens, we have to remember that it's rare, that it happens just one episode, right? Like it's one thing and that's the only thing that's ever happened. It's usually compounded. It's never usually just one incident. But it's cumulative. And so, but it doesn't always, it's not just always thinking about that piece. It's typically then looking at a long-standing history of that. We're talking about generational trauma there at that piece. And that's huge when we talk about that. And when generational trauma and generational trauma, we're not going to get into that a ton. This is, we could go into another training into that as well, but generational trauma, and that doesn't just come into when we're talking about racial trauma, but certainly is a big piece when we're talking about racial trauma, plays a part in that as well. So when we're looking at this, looking at a piece of that, and when we're looking at things like our current events and pieces that are happening right now, compounded onto our pandemic that is happening, it's important to look at how this affects our society, and especially our population who are experiencing this the most. And this is the piece of that idea of generational trauma that we're listening, we're seeing this happening to us right now, but we're listening to stories about generationally how this has happened and looked at for our family for so many years, and they're passing down those stories, and that is taking all of that into account as each incident might happen or situation arises, as we deal with that as we move farther through, and how that impacts someone as they experience things.
Rebecca, there was a question that I think you were kind of speaking to, so I was going to let you go. But the question is, for people with multiple traumas to address, is there a hierarchy that you'd recommend with regard to approaching the different components of that trauma, or do you recommend kind of starting where the client is at? So does that make sense?
Yeah, so we always start with where the client is, always. They have to lead us. Recognizing that when there's lots of things, right? When there's lots of traumas, it becomes difficult. And when the trauma in general is compounded, it can be difficult. But it is always started where the client wants us to start. So kind of like what we talked about before, in the sense of, I've got a patient and they talk about trauma. They may have some sexual abuse trauma, and what they really want to talk about is the feeling of being out of control. Okay, that feeling probably stems from the sexual abuse, but they don't want to necessarily go to what's that encounter. We're gonna work on the feeling of being out of control right now, and what that feels like and where that's at, and we're gonna start working with that, and we're gonna go with where they're at. And oftentimes we're gonna break that down into very small increments and really just start very small, so that, and we're gonna talk a little bit about not getting them out of their window of tolerance, because it's going to become way too much for them. The other thing we have to remember when we're talking about current events, or we're talking about a situation like that, is we don't want to re-traumatize them, right? We want to keep them in a space that they don't feel like they're being re-traumatized. So that's oftentimes where we're talking to them about, where are you comfortable starting and going? We're not going to push them. So we're talking about things like that. It's important. We're talking about things like current events right now, especially when we're talking about racial trauma. A couple of things I want to point out, and I know as I'm looking at kind of time, we got a couple more things I want to share with you, and I know we're running. I got about a half an hour, but looking at the idea of re-traumatizing and some of these current events, I want just reminding you, as we talk about racial trauma, and the idea that as events occur, that those events in general can trigger or open past wounds for individuals who have experienced trauma. So the trauma of the pandemic, current situations that we're seeing now in the news with things like the violence, the murder of George Floyd, when we're talking about those viral displays of violence that are being shared, those can re-traumatize people. And it's important for us to recognize that and look at that through our trauma lens. And I shared a quote here just so people are recognizing this. And there's actually, Shay Martin, who's a Boston-based lit educator, actually has a good article on that as well. If you, it's a short little article that she talked about in regards to that too, if you have the desire to read that. But viewing some of that racial violence, torture, murder, disregard for humanity is disturbing. So is a repetitive trauma for, so when that's shared and shared and shared, it's a continued trauma. So looking at that piece.
Becca, we have another question.
Yeah.
The question is, I'm not sure if you were going to address this or not, but I work with a lot of LGBTQ individuals who experience ongoing trauma in the form of discrimination, rejection, and microaggressions. How would you address this?
Yeah. So that's absolutely, I think that's a huge piece. And what we see with that is, what we see with that sometimes is and in general with some of this is that self-esteem piece that goes in with that too. What we have to remember when we're talking about racial trauma, when we're talking about the LGBTQ community, is those things are very real, right? And it's not about being dismissive and trying to act as those things aren't happening or they don't happen, but it's talking about and processing those experiences as they have happened. It's also about building up and we're going to talk about this a little bit as we go, and I want to get to that treatment need, but it's about talking about building up that empowerment. It's about working on building up some of that area when you go through that. And that's really, I think, a big key piece of that, that self-esteem, that empowerment, identifying that those pieces are real and that they have experiencing them, and validating that stuff, processing the feelings that went around with that, not invalidating that, not acting as though those weren't important, the feelings that went there, processing that trauma, but then building up on that empowerment, the strengths, all of that other key pieces, and we'll talk a little bit about that. So I'm going to go through this really quick because I want to talk about that key, those principles we were talking about. But this is just SAMHSA's 6 principles of trauma-informed care, and we're going to talk a little bit more about some of these key pieces. But that safety, the trustworthiness and transparency, which we've talked about, that peer support. Oh, I hit the wrong button. The collaboration. So we talked about this empowerment, that voice and choice, which I think is what you're talking about. So giving them their strength and experiences are recognized and build upon them, and the empowered to have a voice and choice in their treatment, their goal setting, their plan, but also the empowerment and voice and choice in their life. I have a patient who is, who we've been talking about a lot about. She's a person of color, and especially with everything going on in the world and feeling like she doesn't have a voice and she can't talk about or be able to advocate for people of color, and she can't just advocate in general. And so finding her voice, being empowered, how she does that, where she's at, and allowing that voice to come out, because she's usually very much a vocal person, but around this area she feels like she doesn't have the ability to be empowered because of that. And so changing that vocabulary for her, but also recognizing that experience for her has been very, very real, and the things that she's experienced have been very, very real. And where can she find that voice in a safe place for her? And I think that's very similar to what you're talking about. So the important piece of this is increasing that safety. So providing that support. Providing support for the patients, so that if they're going to shift into a harmful, dysregulated state, what does that support look like? But getting to them to the point where they were less likely to shift into that harmful, dysregulated state, right? What does it look like when they're not in their window of tolerance? And how do they shift out? And how do they feel safe with us, to trust us? How do we provide that safe space within ourselves, in our office, in our organization? How do we continue to let them set their own pace? We also kind of anticipating crisis, right? When we look at some of this stuff, it's not about saying like, okay, you're gonna have a rough day in a week, but it's more about, okay, so we know that, this is an anniversary of whatever that traumatic experience was. Let's be mindful of that. And I'll talk to patients about anniversaries, about court dates, about prison releases, about any of that stuff that could be difficult, and we'll plan for it. And we'll talk about what that's going to look like and how they want to manage that. That empowerment, we talked about this, focusing on their strengths, utilizing that within there, is really, really important to get to that sense of empowerment, because our patients, when we're working with that traumatic experience, often don't have that when we're starting. So when we're working from the very beginning, we want to encourage them for them to create their goals, for them to talk about what they want to work on, for them to tell us where they're at, empower them to be a voice in their treatment, and encourage that throughout as we're working with stuff. So improve regulation is a big one we work on as well. So we're talking about kids, managing that environment, getting those caregivers involved to manage the environment to help with that. So they're not having to shift into that survival mode. With adults, we're doing the same thing, managing that environment, assisting them in identifying what it looks like when they're shifting into that, in that survival mode, out of that window of tolerance, and what it is that they need to help them. So some of the interventions that I use just as that very key piece to kind of keep patients in regulating themselves. And this is not the idea of like, I'm going to keep them in, we're going to talk about window of tolerance, but I'm not going to keep them in this idea of calm all the time, but really just keeping them out of freeze all the time, right? And just kind of allowing them, as they start to recognize that they're starting to maybe shut down, to kind of try to keep them a little bit more regulated sometimes, or if they're noticing they're getting just even higher into a dysregulated state, maybe they're trying to calm down a little bit more, wherever they can utilize this. When we talk about creating a safe space, this doesn't always have to be a physical space. I actually use this as a virtual space for themselves on a regular basis. So I'll do this with a patient in my office. I'll have them close their eyes, take a deep breath, and then I just want them to picture a place where they feel calm, where they feel safe. This can be a real place. This can be a place where they imagine. Often a real place is helpful because they can visualize it better. But if they've got a great imagination, let them go wherever they need to go. With kids, you can have them draw this because their imagination sometimes is better if they draw it out. I talk about all the senses when I get them there. What do they see? What do they smell? What do they hear? And I really ingrain it in getting them grounded and set into that safe space and regulated. And then what we do is we practice being there. I have them name that space. I have them allow themselves to be calm in that space. And then we'll practice in the sense of like, what is a small just irritant that you've dealt with, and then how do we transition back into that safe space? And sometimes getting back to that safe space is just the feelings you had of being calm. Sometimes it's seeing like faces that were in that space with you that were safe and comforting. If it ever becomes not safe or comforting, then you have to recreate a new space. If it's, you may not, that space may transform as long as it continues to be safe. It's okay. Containers the same way. It's that virtual container of just something that is strong, something that can hold any of those feelings, any of those things. Sometimes I've had people put like virtually like people that are frustrating or irritating them for the day into this virtual container. And they just visually see it, put it into the container, and they lock it away until maybe we meet again, until they can talk it through with a friend, whatever that is. But they virtually put it in there, put it away. A butterfly hug is, it looks like, show you here. Butterfly hug is just this, and it's just a bilateral little hug to give them a little bit of calming sensation there. And then some mindfulness and some grounding is some helpful interventions there as well. Utilizing, I do a lot of mindfulness of just kind of talking them through that idea of, again, that safe space is a really great one. I do some of that grounding of 5 senses, some of that breathing techniques, but I will do adding in with breathing in a calm color, breathing out that hot color. So like a cool color might be like a blue, whatever it is for them. And then we kind of let that wash in, and then they blow out whatever that hot color is for them. So visualization with that stuff is really pretty helpful usually. So this is what we were talking about as far as that window of tolerance. And when we're talking about working with patients who experience trauma, this is huge. So we look at that bottom area, which is your freeze. And that's what we were talking about as far as kind of that hypoaroused. So if you look in the middle, we're talking about that comfort zone. That's kind of your middle. That's your regulated, we're feeling cool, we're feeling calm, we're doing pretty well within that, right? So what you're looking at there is remembering that when we go from our comfort zone, right, and we start to move into your like hyper aroused, which is your fight or flight. So if you think about your comfort zone, if you think about it like a stoplight, that's your green, okay? Your go, you're doing well, you're doing okay, you're staying in that window of tolerance, you're pretty mindful there. Physically, you feel good, you're grounded, things are going okay, you're breathing well. You're on your top, you're hyper aroused is like your yellow. We got to be cautious, right? Be cautious where you're at right now with that fight or flight response. So when we start to feel more anxious, more overwhelmed, this is where emotionally we start to get more agitated. This is where we have to we got a warning coming up here. We're starting to get out of that window of tolerance of things. The bottom is your freeze response. Think about this like a turtle in the shell. This is where we numb. This is where that numbing response comes in a lot with our patients. And we've shut down. Shut down at this point, disconnected, autopilot. If we have patients that are disassociating, that is in this piece. What we have to remember is when we're in this freeze response, we cannot go from freeze straight to our comfort zone. So it doesn't typically work like that. To treat the fawn response. Okay, so the question was, what are your thoughts on how would you respond to or treat the fawn response? So you're talking about that idea of when they're, oh good, you like the screen. Oh good, I'm glad you like this one. Yeah, I think this is really super helpful. And so when we're talking about that fawn, when you're talking about that fawn response, what we're looking at is a couple things. Often when we kind of talked about this earlier, in the sense of when we're working with trauma, when we get to that freeze response, it's too much. It's too much. It's an overload. So we can't do it all. And that's where we have this numbing, this fawn response, this idea of shutdown, right? And so we need to really, a couple things. We've got to meet where the patient's at, right? Are they able to, do they want to continue to work on this right now? So I will talk with patients when they get to this point where they're done. They're in this freeze response where they're unavailable, they're shutting down. There's a couple pieces we can do. We want to de-escalate some from here. That's a key, right? Because we're not in that window of tolerance anymore. And so continuing to work on that trauma in that freeze response is not going to be helpful. Or really they're not able to. So the first thing we need to do is de-escalate that, right? The other piece is that's showing us that whatever we're working on in that moment, if this is happening during a session or whatever that might be, is too big. So we've got to break that down. We've got to break that down into smaller pieces. So that's going to be pretty huge. So that's how I would work on that. That's how I'd work on that piece. The other question here is, how would you coach a person to help another person who is disassociating? So what I would say to you on that is this. How would you coach a person to? So there's a lot of pieces to that. And I will be to be very honest with you, I am myself getting a lot of training and working with folks who disassociate as I'm working with them. So what I would say to you right now is getting that supervision and that training with them is important. If you know that you're working with someone who disassociates, as you're working with them, having them move while you're working is good. That keeps them grounded and active while you're working with them, and keeps them often connected with you. I am not an expert in disassociation, so I really don't feel comfortable giving that guidance, just because that is not my expertise.
Well, and it sounds like this question was more about coaching someone, like, well, it sounds like a family member, possibly another provider, on working with someone dissociating. So I don't know if it's even taking a therapeutic approach to helping support systems around a person who's got trauma, Rebecca?
Gotcha. Yeah, that, yeah, and then that makes sense. Thanks, Jess. And that, unfortunately, is just not my expertise in general. So what I would say to you is to get some, as far as disassociation, I'd have to defer that one a little bit. So hopefully it sounds like this slide was helpful for some people as well. And again, we're going to send these all out. But the other thing you can do with this slide, and what I find really helpful, and you know, I got this slide from my supervisor, who I get supervision from, with EMDR supervision from. And so what I do with this slide is to work with my patients on figuring out what each state looks like for them. So what does it look like when they're in their comfort zone? What does it feel like? What does it look like? What does the world look like for them? What does it look like when they're in their hyper-aroused state? What is helpful for them when they're in their hyper-aroused state? And what does it look like when they're in the freeze response? And what is helpful for them there? And that is helpful as well for that regulation when we're working with patients. And this is a great slide, well, you know, to utilize when you practice, but also when we're talking about education with our patients and allowing them to recognize what, you know, where they're at in their window of tolerance, and assisting them for that self-regulation too. So what we talked about is the idea of when to refer to a psychiatrist. And certainly psychiatry comes into play at certain periods of time. But I just want you to remember that trauma in itself, right, can't be trauma in itself can't be treated with medication. Obviously, some of the symptomology from that could be helpful. So we want them to be working, if they're able to, if patients can work with therapists, even just to be able to learn that self-regulation is huge. So the medication, if it can be combined with therapy, obviously with anything a patient's dealing with is kind of what we're striving for. But when we can refer out is when some of that symptomology gets to be too much to handle. But we always want to try to refer to psychiatrists who have a knowledge in trauma, so that they can understand and treat a patient based on that lens.
Rebecca, just a heads up, we're at noon, so we're at time. So I just wanted to acknowledge, I know you said you had some flexibility, so if anyone out there is looking to hang on for a couple more minutes, Rebecca can finish a few more items here. Dana or Ryan, I don't know if you guys had anything that you needed to say, just in case some people start to log off here at noon if they had appointments booked. But otherwise, Rebecca will continue and make some time for discussion at the end still for anybody who has a couple extra minutes to hang on.
And I think we left this at this was my ending of it here, so which is perfect timing. But I think just remembering that medication can be a helpful piece within our treatment, but it's helpful when we have that team collaboration piece in there, obviously, and our team is working together, and that trauma-informed lens is probably the biggest piece that's important. So looking at that is going to be key. So my last slide is just my contact information for anybody who has any questions. Moving forward, if there's anything that you felt like you had questions we didn't get to talk about today, or if there's something you think about later, you're going to get all these slides, but if something comes up, or if there was something you just didn't want to throw out there while we were talking today, feel free to shoot that out to me. I have no problems talking about this after the fact, or via email, or if you want to give me a call, that's fine as well. If there's any more questions right now, we can certainly talk about that too. I really appreciate you guys getting on. I know this is a little bit different venue. But thanks for sharing your morning with me.
Thank you, Rebecca. No, it's a lot of information, and I think if some of you are looking for further trainings, or I know that in a 2-hour training we're not able to get into some of the hefty treatment aspects of trauma, and of course there's entire treatment models dedicated to this, but if you have a specific follow-up training that you think would be a good follow-up to this one, which focused a lot on that trauma-sensitive lens and assessment of trauma and some of the just kind of key components of treatment versus actually outlining, let us know. We definitely are interested in hearing any feedback that any of you may have about kind of further trainings in this area. I know there was a couple questions about mandated reporting that we kind of answered. I know that's an uncomfortable area. There was a question that didn't really, I didn't, we kind of passed because it was already past that point, but about reporting past trauma. So certainly, as we're doing some of this trauma work, you may have an adult or even an older adolescent client that reports something that happened a long time ago, maybe for the first time. And again, I would advise everybody there to kind of speak to your own, and I'll let Rebecca chime in on that too, but speak to your own agency, your own supervision, your own consultation as to some of the specifics of when there is a need to report past trauma, but generally, my take on it as a 15-year professional is that we are, as mandated reporters, we're always looking for what is the is there a current safety issue? So does that report of past trauma reveal something that, you know, by reporting it, that we could do something to prevent ongoing, you know, safety, you know, for either that person or another person? And so, you know, other than that, we would advise to report for that client if they're ready to you know, to report that to authorities. But you know, that question about past trauma, I think, is definitely one that can come up when you're for the first time kind of unveiling things with clients, or they're getting comfortable speaking to you. And in general, you know, keeping in mind that our mandated reporting role has to do more with current safety and security, you know, specifically for that person, versus, you know, feeling like we're being the authority on you know, reporting a crime in the past. So again, Rebecca, I don't know if you have any other comments on that, or I do see some other questions coming in as well.
Yeah, I was reading you were talking, sorry. Yeah, no, I agree with you. I think we have to kind of defer sometimes to where we, you know, what the policies are to where we're working, but I think that's all good feedback in looking at some of that.
I see here there's a request for having that one slide that you had, that, you know, it seems like a good training, a good slide for coaching and educating clients about their current state, so that comfort zone. Do you think it would be possible, and this might be a question for Dana and Rayanne as well, to send that as a separate PDF in addition to the PowerPoint?
Yeah. I should be able to put that separate.
Yes, and we can, I mean, Rebecca, if you can do that, we can send it on to everyone with everyone's email address.
Okay, I'll send it over to you guys.
Awesome. Well, thank you so much, Rebecca. That was awesome. I think extremely informative and helpful. It looks like you're getting some really great feedback too. So thank you, everyone. Any other questions, or Rebecca, anything else that you would like to add?
No, I think that, you know, I know we condensed a lot of stuff in 2 hours. So as Jess said, if there's things that you guys feel like would be helpful, please let us know. And we, you know, if there's things that we can expand on, certainly that's helpful for us. And hopefully we will see you all again, maybe in person for the next one. So.
Sounds great. All right, take care, everyone.
Thank you.